medicine. Sherri Ozawa has been a leader in patient blood management and bloodless medicine for more than 2 decades. She has a background in critical care nursing, which has enabled her to help create one of the most widely known multidisciplinary PBM programs at Englewood Hospital in New Jersey. She's lectured internationally and throughout the U.S. and focuses on creating and implementing sustainable, organized PBM programs. She's very well published and continues to be actively involved in research in the field. She's also worked with the Joint Commission and other regulatory agencies to help advance patient blood management. She is currently she has served as an investigator on the first U.S. federal government grant via the Department of Defense funding for creation of an organized training program for doctors and other healthcare professionals in patient blood management. She's a founding member and immediate past president for SABM, and she's currently serving as a director of comprehensive patient blood management delivery and operations for Accumen. This is a company that specializes in implementing comprehensive PBM programs across the U.S. She has also been selected as the only nurse contributor to the WHO PBM Policy Brief Implementation Panel. She's received awards of excellence, including the Award for Excellence of the BMSS in 2019. Sherri, we're happy to hear from you this morning.
Thank you, Erin, for the kind introduction. It's a pleasure to be with all of you. I appreciate the invitation and greetings from Skopje, Macedonia today. So I'm going to share my screen. I apologize that I'm just on a laptop here. So let's see. Is that working? Can we see it? Okay.
Yes, we can see it.
Yes, looks good.
All right, now, thank you. All right, awesome. Thanks, Erin. Thanks, Nat. Okay, so a little bit, again, background on compassion. We've heard a bit about it already from previous speakers, but I'm going to specifically tie this certainly to bloodless medicine and surgery, but also a few points specific to nursing history a little bit, and how our current environment that we all work in a sort of post-COVID world, but a world that was already strained in healthcare resources and lots of pressure on our healthcare providers, particularly nurses, and how that impacts what we do, and particularly in bloodless medicine. So you heard RA already referred certainly to this concept of patient-centered care, where this is the definition from what was formerly known as the Institute of Medicine, now the National Academy of Medicine. And I'm not going to read you all these words, but I kind of highlighted the things I think particularly tie to what we're talking about in bloodless care. And you'll hear me use PBM, as you've already heard, John, and RAA. You know, there's certainly a lot of crossover between PBM and bloodless. That's not the topic for today's talk. They're not interchangeable. There are, unique aspects to both, but there is a lot of overlap in the things we're doing in PBM and bloodless. And so you might hear some interchange of terms, but I think it'll be clear. But really for both PBM and bloodless, responding to our patients' preferences and needs and values, and acknowledging that our patients are not just moments in time and bodies in an exam room or in a bed. They have whole lives, right? And we're patients too sometimes, and they're made up of all their experiences, their stories, and their knowledge, and those have formed their values and affect the choices that they make. So again, using these terms, patient-centeredness and compassion, those are easy words to say, but you can see that no matter what country we are in or practicing, sometimes our systems use the words a lot, but when we see in an application, they're often built around other things, and logistics are the pressing needs, and really our patients' care. And I think bloodless, again, for all these years has been a demonstration of how you can keep pointing back to the patient and keeping them at the center. So I'll speak a bit about, and I apologize, a couple of these slides are from my talk last year, not a lot of them, but I think because I was asked to speak specifically about where nursing and compassionate care and bloodless work together, a tiny bit of history on nursing. It really was highly gendered, which I'll talk about in a moment, but rooted in these vocational norms of motherhood and homemaking. And it evolved to the definition of the ability to be these three main C's: compassionate, caring, and communicative. And although we use the word compassion a lot, now in healthcare into sort of both with physicians, nurses, and others. It actually wasn't that commonly used in healthcare literature and healthcare settings actually until the HIV crisis. And I'll talk about more of that in a moment. But that is really how nursing has evolved to really embody, in part, compassion. And these are highly valued skills that are critical to, as we said a moment ago, patient-centered care. They're often perceived as sort of soft skills, but they are actually very, very deeply valued by patients and families. And as we already heard, are absolutely related to not only the patient experience, but also actual clinical and quality outcomes. So just some fun stuff right from the internet, because we, of course, we believe everything we see on the internet. But this was the last time I could find this particular survey that talked about the most trusted professions in the United States. Nurses, every time they do this, every few years, nurses do come out up at the top, as you might imagine, Congress people and lawyers down at the bottom. And again, we also believe everything we see on Twitter. I just pulled this yesterday from this interesting feed, if you want to follow it, World of Statistics, some fascinating stuff that's shared. But it also sort of did this widespread global survey of who do we trust the most. And not surprisingly, nurses come up near the top, pharmacists higher, which was surprising, and down at the bottom, as usual, politicians, etc. But I think it's not a surprise to anyone in this call that nurses are seen as a very trusted profession, but that also comes with a lot of responsibility when it comes to certainly working with our colleagues, but most importantly, our patients and our families. So a little bit more history as nursing changed and evolved into what is now modern nursing. Those earliest nurses, as we described a moment ago, they actually never went to school, but things changed a lot during the 19th century. Their role was expanded to include soldiers during wartime, and during the 20th century, specialties started to develop, certainly as they exist in medicine. Formal schooling, and particular, again, nursing specialties and subspecialties like orthopedics, psychiatry, trauma, etc. And now, as we all know, advanced practice nurses, again, the practice may be different in different parts of the world, but it is very common, certainly, for nurses to be in advanced administrator roles, even being CEOs or chief clinical officers of large health systems in North America. But they may be in clinically facing roles, business roles, administrator roles, legal, ethical roles. So really a very, very fast evolution of the practice of nursing, and very expansive. Again, that's not the same in every country, but a lot of opportunities and diversity of practice. So back to the topic we're talking about today, compassionate care. And again, I pulled some things from specifically the nursing literature. And this was the definition as expressed in the nursing literature of compassion, this inner feeling of another person's suffering, motivation to help and alleviate that suffering, and the four primary parts of that being wisdom, humanity, love, which I think is an interesting one. We don't often use the word love, right, in actually the clinical care that we exercise, but it is considered academically a part of what is defined as compassionate care, and empathy, which I think our previous speakers already captured. So what about specific to nursing and the term compassion, or the use of the word nursing? As I said a moment ago, and we're not here to have a gender discussion, but the challenge is that this is a very highly gendered history, both to the nursing values overall and to specifically the use of the word compassion. Not necessarily a bad thing. The history is what it is, but you can see from those vocational norms that it was a highly gendered experience. And these visions of nursing as a vocation steeped in caring, sympathy, and selflessness were at the heart of the transition, as we spoke about a moment ago, from a trade to a profession in the 18th century. And so on the right, you see really kind of a fast progression. This is UK based, but in 1843, this is a depiction of a nurse named Gump, who was in a Charles Dickens novel, and she was a pretty saucy character who had questionable morals and did all kinds of interesting things if you're a fan of English literature. But really, and that was sort of shaped in large part, at least over the pond here, that the perception of nursing as sort of this interesting little segment of society. But then just a few years later, Florence Nightingale, as you see in the bottom picture, began her career, became a nurse in 1851. And because of her work, both as a trialist, as a practitioner, all the work she did in the Crimean War and other parts of her career, really developed this as a profession, as the parent of the modern nursing as we see it today. So it was a very fast and interesting progression, but she is really the one who then brought into, in a professional sense, this concept of compassion and tied together nursing to these other qualities: virtuousness, loving, kind, unselfish, gentle-hearted, is some of the terms that she used in her literature. So interesting history if you want to look at Dickens. So that term compassionate care, as I said a moment ago, was actually not that common, although again, we use the word a whole lot, certainly today, but through our care, the term compassionate care was not really applied to nursing until the 1970s. And then it started to appear a lot in the literature during the 1980s and in subsequent decades till now. But it started really, most of the articles refer to caring for people with HIV and AIDS, and it linked compassion in the nursing literature with incurable and stigmatized patients. I think it's an interesting point, not that we would classify our bloodless patients as incurable, right? They don't have a problem because they make choices around transfusion, but stigmatized for sure. So I think that we can learn some of the lessons of these years in the way that the term compassion is used alone, or not specifically about bloodless patients in these articles, but it's an interesting evolution of the term. From that same nursing literature, we see lots of diagrams. This is kind of the academic depiction of what does compassion and where does it fit into the structure of nursing practice. On the bottom, there's the whole practice environment, and compassion is sort of this underpinning foundational piece, again, broken down into these patient-centered, individualized needs, et cetera, with communication as an important part of it, with the intention of alleviating suffering. So a visual depiction, again, of what compassion looks like in the nursing literature. This, of course, was well demonstrated. Again, sometimes these skills were perceived as soft skills. Don't love that really approach to things. And they didn't seem so soft, certainly during COVID, when nurses understood that need for human connection at a time where patients did not have their families or loved ones around them, and came up with all kinds of strategies. Just one in the picture we're all familiar with. We were all behind shields and masks and all kinds of protective equipment. There was a real need for human connection. And again, those skills didn't seem so soft when this was the connection that patients, often sick and dying alone, had to other human beings. So how does that, again, we're here to talk about bloodless care today. How does some of those lessons and a little bit of that history relate to what we do, and those of us who are interested in specifically bloodless care? So many of the patients that we take care of in these types of settings and these programs have actually been, and I don't use the word lightly, traumatized in other healthcare settings, maybe traumatized by their own histories. As we said at the beginning, patient-centered care means our patients come with stories and history and experiences, and the history of this patient population, again, is long and has been very variable. So traumatized is not the wrong word. These patients have very specific values, value-based needs and preferences, as we've already discussed, and the communication around this must be delivered with sensitivity and compassion. We are asking patients to make real-time decisions based on long histories, right? And some deeply held personal values, maybe religious values, maybe others. But we're trying to translate modern science, modern applications, modern clinical techniques into a language that they understand. It's often nurses at the forefront in doing that and having that communication in a way that's digestible and meaningful to patients. And a big important point for those of us who are working in bloodless centers or in these programs, we know that the patients we take care of are often very far away from their normal days, their normal social structure, their emotional support systems and spiritual systems. So that creates a level of risk. There's an interesting article there on the bottom that talks about the role that social and emotional support play in taking in care for our patients. And again, this isn't just conjecture. There's actually real, true risk and outcome negativity when patients are away from that. So all that, again, necessitates the need for compassion, and often in bloodless care and all care, nurses really embody that. A little bit about our challenges in compassionate care. Again, not specifically to bloodless, but it does all fit together. So compassionate care in the nursing literature appears as a value in nursing. It is reflected in nursing code of ethics and our standards, pardon me, in our nursing health policy guidance. But what we are seeing increasingly in the nursing literature is lack of compassion is increasingly reported. There's a lot of reasons for that. I'm going to just touch on a couple of them in a moment. But what happens when lack of compassion shows up in our day-to-day practice? Actually, it's bad for our patients, not a surprise, right? Patients are less likely to adhere to what they need to do as we are trying to teach and deliver care, and nurses are less likely to adhere to their own standards. We lose dignity in caring for our patients. We can impede their patient rights to quality care. Patients are dissatisfied, as referred to by other speakers. We can cause unintentional or sometimes unfortunately intentional harm when we lose this compassionate aspect of our care, and again, directly, in fact, affects our patients' morbidity and mortality. And I'll just spend a moment talking about this increasing concept, and actually this is pre-COVID. There's even more in the literature during and post-COVID, this concept of both compassion fatigue and compassion satisfaction. We won't get deeply into it, but you've heard it, I'm sure, all as practitioners discussed as an important part of how we remain resilient and continue our care in a compassionate way. But this compassion fatigue is described as this progressive and cumulative outcome of prolonged, continuous, intense contact with patients, self-utilization, and exposure to multidimensional stress, leading to compassion discomfort that exceeds endurance levels. This, again, is from the nursing literature, but I think it certainly can apply to others as well. And this state where compassionate energy is beyond restorative ability to regain it. So it affects our physical, social, emotional, spiritual, intellectual abilities in a progressive manner. So again, I think even without this academic article, we know that this is real, but there are definitely descriptions of this in the literature. This was an interesting meta-analysis of several studies that actually looked at nurses' daily practice and how their day-to-day professional lives affected their compassion, satisfaction, fatigue, and burnout using a quality of life scale. Looked at about 4,000 patients around 40 years old, most of them female, not surprisingly. Most were married, and their average years in nursing was about 13. And this was the conclusions of this meta-analysis. The long story short, again, not surprising, but this really is being studied, this concept of compassion fatigue and compassion satisfaction, that stress and negative environments promote actually this fatigue. And we can do something about that with positive reinforcement and social time with meaningful people in our lives as nurses and others too. Compassion fatigue associated with burnout, and the themes that came across actually transcribed into physical expressions from these nurses in these studies: worn out, walking on a tightrope, unbearable weight on their shoulders, alone in a crowded room, and concept of who has my back. And we often talk about increasing resiliency of ourselves as nurses and physicians and others, but there are a lot of systems issues associated with this too. And I'll just finish up with this one study which really looked at that, and I think this intersects in an interesting way with bloodless centers. So this is an article actually from the British nursing literature on compassion in nursing as a solution or stereotype. Very interesting article, but it sort of talked about the way that we describe compassion as this easy thing to say, and when people lack it or they somehow are not showing it in their practice as nursing, it's their responsibility. It's each of our responsibility to figure out how to get it back or to express compassion. Where in reality, and again, create resilience. When in reality, this approach really overlooks the need for organizations, not just individuals, to be charged with supporting compassionate care. So there's this concept that from the same article that sort of this individual focus on compassion can call out the bad apple or bad apples in the bunch of practitioners, those who are not embodying compassion or expressing that. But really, those labels on individuals are not helpful, and oftentimes it's really a systemic failure, is what this article points to. And I thought that tied really well back to the success of bloodless medicine. We've said it over and over again over these different years on this conference and others, that when there isn't systemic support, both of bloodless and of PBM, these kinds of initiatives can easily fall apart, right? Both from an individual level, we're talking today about compassion, but from a structural organizational level. So it really just fits together that when we build for success in bloodless and PBM, we need that infrastructure, that organizational structure, not all the weight of any individual program or initiative on one person. That's too much. So this patient-centered compassionate care in bloodless, again, specifics to bloodless, and I won't read all of these to you because you'll be hearing a lot about it over these few days, but that concept of patient autonomy, effective care, the values and preferences, collaborating with our colleagues, the emphasis on our patients' overall well-being with respect to their personal beliefs and their stories and experiences. And in the end, it isn't just nice to do, it isn't just being nice to people. Incorporating this compassionate approach actually does improve their clinical outcomes and our own professional outcomes and the way that we feel about our daily lives. So I pulled just very one level. This is not a deeply clinical discussion, but I thought it was an interesting example from a bloodless center of a patient. I mean, I'm not having a long discussion here about ITP versus TTP, et cetera, but it was a patient who's 28 years old. She herself is a healthcare professional. She was fatigued. She was reporting bruising. She went to her PCP. She had a low platelet count. Her PCP said, I think it's ITP, said to go see a hematologist. The local hematologist got double worried. Her platelet count continued to go down, referred her to a local hospital who really had no concepts of sort of incorporating what we just talked about, her values, her preferences, and wanted to approach this in a very traditional way, not necessarily a clinically wrong way, but a traditional way with pheresis, of course, using plasma. She instead made a choice to go to the emergency department of a bloodless center, had consultation with hematology, of course, laboratory medicine pathology involved in this multidisciplinary discussion, took into account her needs, her wishes, her preferences as a patient for whom blood was not an option. So did something a little bit different from what maybe not just traditional, but the normal clinical course, made some changes and adjusted the approach to therapy, pheresis with albumin as an example, which was acceptable to her instead of the plasma exchange, which would be typical. Again, this is not a deep clinical discussion of the management of TTP, but showed that when we really do listen to patients' preferences, there's a difference with saying, sorry, can't do it, can't take care of you, go find somewhere else, or don't get care at all, to really accommodating these wishes in a way that respects the autonomy of patients, but also delivers the best possible care we can in the environment. And here she is, looking good and happy for care. So I'm going to finish up with a little bit of a slight soapbox on the nurse's role in patient blood management and bloodless. I get asked often, and I'm privileged to be able to speak about the role of nursing. But I think that we actually need to turn this conversation a little bit on its head as we talk about this. So we often hear, what is the role of the nurses in bloodless and PBM? It's a kind of a limiting question, and I want us to sort of expand our minds, given the evolving and fast evolving world that we are living in this field of PBM. And again, bloodless is connected, not all the same, but many connections. So we really don't hear that same question in many conferences that we go to. We don't hear, well, what is the physician's role in bloodless, right? It depends on in the context we're talking about. So I think that it's sort of a limiting question to approach specifically just the nurse's role in bloodless. The scope of practice is different from physicians. And again, the levels of responsibility in nursing are very, very variable. And you will see this in bloodless centers as well as PBM programs. So there are nurses who work at the bedside, of course, in patient-facing roles, advanced practice nurses who work in primary care, inpatient care, administrative nurses, leadership, right? So we really need to, I think, reframe this question that we sort of keep hearing, those of us who are nurses in this. So let's stop asking the nurse's role in PBM / bloodless. Really, what is PBM's or bloodless's role for nurses? I know it seems like a small adjustment, but it really expands our mind to not this sort of limiting view. So while nurses have an active role in PBM and bloodless, especially this aspect we talked about today of compassionate care and communication, the goal is not to have tunnel vision to just one type of nurse. Nurses have this wide scope of responsibility across the continuum. So nurses don't play a role in PBM / bloodless play a role in nursing. There are specific interventions that nurses can implement. As we know, many of these programs across the world are led by nurses of varying backgrounds. This promotes that patient-nurse relationship, and very many roles in nursing in different levels of experience play a role in this. So this really big variation that's available in nursing, very, very interesting profession, right? With all the different paths and specialties, etc., really make nurses extremely well suited to handle many avenues of PBM, including, again, not the same, but absolutely related bloodless care. So just something very quick, which is not specific to compassion, but in terms of defining the specialty, there is a subgroup of nurses working on behalf of SABM to work with the American Nurses Association, which does have lots of global tentacles, and actually creating PBM nursing as a emerging specialty, just like there are other specialties in nursing. This has really been an exciting initiative, and the American Nurses Association is pretty energetic in working with us to really define this as a specific nursing specialty. So more to come on that. Can't reveal it all now, but it's not fully baked, but really done some nice progress. So please keep your eye on that. So why does it really matter that we start to define this PBM/related bloodless role? It aligns with other nursing specialties. It requires a demonstration of this experience, active career activity, and knowledge base. There are career implications to this, positive recognition, of course, just personally, but in the professional setting and regulatory aspects of this, and recognizes this unique and specialized expertise of nurses who work in these roles. And again, as I said, there are global implications to that. So I'll just to finish up, thank you again for the time. If anyone on the call is a student or a resident, here's a QR code for you, membership with no strings attached to SABM, Society for the Advancement of Patient Blood Management, is available to you at no charge. We invite you to join during the time of your studentness or your residency. So please feel free, whether you're a nursing student or a student in other specialties, please feel free to scan that QR code, or you can contact me for more information. And that is my contact information for any future questions. So thank you again for your attention, for having me here today.